I think everything started with my friendship with Pete Niklas, who was at the time the co-founder and chairman of Boston Scientific. I was at that time, believe it or not, teaching rotational atherectomy in Japan and being full-time faculty here at the University of Texas in San Antonio. So I did quite a work in Japan according to Pete Niklas. So the time my father, who was my late father, who was a physician in Poland, he told me, "Hey, I'm glad you're in Japan and US, but in Poland we have a crisis in terms of myocardial infarctions, as you pointed out." So because of my also long friendship with Julio Palmas, who was my co-faculty member at the university, and we worked together, I was able to start bringing stents to Poland, rotational atherectomy and other stuff. And then somebody told me that there's a fellow in Silesia, at the time, Dr. Bushman, and perhaps I should go there. In Warsaw, I was not too popular for many reasons. I will not go back too far, but so that's how the whole thing started. One person who I would mention, he's Dr. Kiesz, who was like a business brain behind a so-called interventional approach, and my idea was that we don't need to build big hospitals. That everything actually in the hospital runs around the cath lab. At the time, the heart was, the most. The myocardial infarction was the biggest problem in Poland, and that we have to go to the Poland B, so to speak, to the province, and then start little centers there, because the patients will not make it to the big university cath labs in the big cities, and that's how it started. We started actually from one clinic, and now it's close to, I think, 30 or so. And then, I have to give a credit to the colleagues in Poland, to the younger generation, so to speak, that they took off after we showed them a little bit and got some equipment and stuff. And of course, Poland is now a very affluent country. It's not what it was 20 years ago. By the way, we will be celebrating 20 years anniversary of American Heart of Poland. And then we don't do only myocardial infarctions. We do EP, we do vascular surgery. I had a bunch of excellent colleagues, including Przemek Nowakowski and others, in my center here, when I show them my techniques below the knee, above the knee, and then and then we actually. Dr. Bushman performed the first carotid stenting in Poland, hooked up to my phone here in San Antonio at the University VA hospital, when I gave him step by step, because I was third, I think, in Poland, in the world, with Julio Palmas, when we did carotid stenting following Gary Rubin trail blazing, so to speak. So that's about it, So, do you hear me?
Your session, you have great speakers.
Okay.
We have a lecture by Gary Rubin, but we didn't take the liberty of waking him up because he's even further to the west from you. We have
don't wake him up.
We have Dr. Chwala. Go ahead. It's all yours, Stefan. Back to you.
So this is actually the case which I did like maybe 10 days ago or so, and then I have to click twice. They told me I had to click twice. There you go. So this is a fellow whom I know for a while. I did the first. Why I wanted to present this case, because this is an interesting case. He had a carotid stent with exact stent done. Probably like 2 or 3 years ago. He is vasculopath, but he's in his 50s, and as you can see, he kept smoking. He's typical San Antonian, has diabetes and smokes. And then he comes to me, has kind of strange symptoms, maybe TIA, etc. And we realized that he has stent in the right carotid, that he has contralateral disease, but there is something going on under the stent, and I'll show you this in a moment. So let's go to the. So this is a picture. This is the right carotid, as you can see. And what I wanted to point out to you that the stent is patent, but the progression of disease is in the right common carotid. Okay, so you would expect that maybe he will have a instant restenosis, which is actually not that frequent, but because these are large stents, but the disease actually progresses in the right common carotid artery. You can see that the right external carotid artery is also compromised, and keep in mind that he has contralateral disease. On the top of everything, he has peripheral arterial disease and coronary disease, and I fixed his heart several times already. So obviously, this is when the velocities were quite high, and this is what I told him. Look, this is not a surgical candidate. This is right common carotid artery. Is not surgical patient. And the other thing is sometimes disease like this happens when you have radiation arteritis. Folks who have radiation to the neck, let's say they had a throat cancer and etc. Because that was actually the first case we've done with Julio Palmas in the early 90s, when there was a patient who had string sign, and maybe one vertebral was off, and everything else was actually clogged up because the patient had the radiation to the neck. That was actually my first case I've ever done. So how do we approach this? Obviously, you will see in a moment. Okay, let's go to the next slide. So you can see there's ample shield. There is obviously distal protection, and we decided to proceed with direct stenting. And see, the stent is already deployed. This is the closed. This is the exact stent, which essentially has a very good cell structure. It's a closed cell structure, and which we try to trap the material. In carotid stenting, as you all know, we should not go for the ideal result unless we want to have a stroke on the table. We just want to trap the potential embolic material, by the cells, and hopefully that will go ahead. You can see the stent is already post-dilated, and in this projection, I am very happy with the result. I don't care about the external carotid. This is the final result. If you can play it, can you play it? Yeah. So you see, this is where I finished the case, because we don't want to have a zero residual. It's nice to leave sometimes 20-30%. And this patient was asymptomatic. He was discharged actually the next day, and he's waiting now. I'm going to wait a little bit of time, maybe 2-3 months, to do his contralateral carotid, which is internal carotid artery stenosis at the ostium. There is this fear of hyperperfusion syndrome. I didn't know much about hyperperfusion syndrome in the early 90s, when actually I presented, I think in Miami at ISET meeting, 20-some cases with some 2.5 years follow-up, when we had a very sick population at Audie Murphy VA Hospital here at University of Texas San Antonio, when I was actually a chief, and with Julio Palmas and others, who had a group of patients with unstable angina with TIAs. So question was where to start and what to do. We thought that stroke is probably more devastating than myocardial infarction, if you can, this is like apple and oranges, but still. So we started actually from, we had a bunch of patients where we actually wrote up one in CCI, one case when patient had a bilateral TIAs and unstable angina with some impressive STT changes. So we fixed both carotids at the same time and did 3-vessel intervention, all done at the same setting. So we had this crazy group of patients who've done some crazy stuff at the time in the early 90s. And I presented this at Barry Katzen meeting in Miami, and there was silence after I presented because, and somebody said, Stefan, you must stop the stuff because for 1 hour we discussed and we tried to prove that this kind of stuff is never going to happen. Well, it did happen, but maybe it's a good thing that there's not a golden standard. But anyway, so this is this case which I actually did, recently. As I promised you, I'll present this. Unfortunately, we couldn't. Julio couldn't find, and I couldn't find my first case, which we did, 20-some years, almost 30 years ago. But so I'm open for discussion.